First of all, is thank you for giving me the opportunity to speak. And secondly, I do want to recognize Palmetto GBA has been, should be recognized for at least recognizing that the code 0376T into a covered group, along with 0191T, which is great. And so I know that was an early first step that you guys took, and that was very much appreciated. I think from my standpoint, iStent inject versus the original iStent. The inject is actually a little more difficult to insert, believe it or not, than the first one. It's not what I had initially anticipated before I started using the inject. But while it carries or has multiple stents inside the device, it's actually trickier to inject because of the way the device works. Patient fixation becomes a bigger deal. Pressure with the gonial lens becomes a bigger deal. Visualization is even more important because you've got to be able to visualize that the actual point on the end, or the trocar, I guess you would call it, on the end of the injector, to make sure it's 90 degrees perpendicular, which it not always is. Once you place the first stent in, visualization becomes tougher. Often we have to pause, place more viscoelastic in, sometimes irrigate and flush the eye out and put more viscoelastic in order to get optimal visualization for the second stent. And based off of the first stent, in terms of did we get blood reflex, etc., we might make a small modification to the second stent. And then there's always the risk of over-implanting, implanting too shallow or implanting too deep, which were not issues that we had with the first iStent. So in my mind, it's trickier to be doing these procedures with the inject, and yet I like the inject itself. I think the delivery system is slick, and I like the opportunity or the ability to insert more than one stent, and I guess that's probably the purpose of today's call. I've been very, very supportive of staying within all of the guidelines for what insurance coverage provides, both for the first and second stent. But at this point, I feel like I'm not doing this in the best interest of my patients if I'm not able to use multiple stents, yet it does take a significant amount of time for the surgeon to implant the second stent. And there has been good studies that have shown that multiple stents lower the pressure more than just one stent alone. And so I do really feel that should be considered. I know in the language they talk of it as so-called dosing of multiple stents, but I really feel that additional payment for the second stent should be warranted. I think in the past with other stents it gets reimbursed at 50% of the rate or whatever, which is fine, but there's extra work effort involved. There's certainly benefit to the patient, and I would like Palmetto to consider reimbursing on the professional fee for the second stent.
Well, thank you very much, Dr. Solomon. We appreciate the insights that practicing physicians are bringing to us concerning these technologies. As you know, part of the payment structure for a procedure is not only based on the actual physician work, but other factors such as overhead and pre- and post-operative care, which in many cases are pretty much the same whether you do one procedure or you do an additional procedure at the same time. So, that all has to be taken into consideration, but certainly the look at the physician work in this case appears to be something above and beyond placing a single stent. So we will keep that all in mind as we go forward with this LCD.
I appreciate that. It is significantly more work even than the first stent involved with the original iStent. The inject, inserting one of them actually is more work involved, but inserting a second is significantly more work. But I may be misunderstanding, but when the multiple stents are placed in other areas of the body, I thought that there was additional reimbursement for that. In terms of the post-op recovery, Perhaps you might say it's no different whether there's 1 or 2 or 3 stents, but I would say that, quite honestly, we watch these patients extremely closely because we're trying to get the intraocular pressure optimized, and ideally, most of my patients want to be off of their drops. And so we'll do the procedures, we'll stop their drops, we'll follow them for a few weeks, let their inflammation from their cataract surgery, we bring them back multiple visits, at least I do, and I'm sure most of us do, to follow that intraocular pressure to make sure it's where it needs to be, and if it's not, we might need to restart a medicine. And so it's actually fairly labor intensive, significantly more than what you would think with the postoperative care coverage that's already included. I think most people are doing significantly more work than would be anticipated, which is fine. We want to do what's in the best interest of the patient. But the studies that I'm aware of have shown an extra 2 to 3 millimeters of lowering per stent. The ability to provide a second stent can often make the difference for a patient whether they can get off of their drops or not. And then in my world, I'd like to provide the best I can for my patients, but I would like to be compensated at least for the additional work that we're doing.
Well, we did take into account all of those, the post-operative vigilance, which is significant in these cases, and I can see where, it does take a lot of fine-tuning if you're going to get somebody's pressure into a range that you think is appropriate and sustainable without the medication. So I can assure you I have other ophthalmologists who've also weighed in the past, and we did take all those things into account, and we will do so with this particular device and procedure as well.
Thank you very much. Appreciate your time.
You're welcome. Thank you.